It is really an honor and a privilege for me to be presenting at our first ever virtual SAGES meeting, and I'm grateful to the leadership for this invitation. I'd like to take the next 10 minutes or so to discuss a very important topic, how to disclose adverse events in surgery. I have nothing to disclose. So my objectives today are to impart that before any reporting can occur, physicians must understand the difference between error, exercise of judgment, and negligence. Secondly, I will summarize the current roadmap for disclosing bad news to patients, and also how to mitigate medical legal risks, especially in view of apology laws. Next, we will review internal reporting processes, especially the root cause analysis, and to what extent this process is privileged. Lastly, we will touch stress management for physicians, which can be overlooked. So a very important concept to understand is that error does not equal negligence. An error is an injury that occurs during the course of medical management of patients. However, negligence is failure to provide a standard of care. In other words, delivery of substandard care. And in closed claim analysis studies, negligence was only found in about 15 to 30% of cases, and rarely present in most alleged cases of medical malpractice. Error in judgment is used frequently in medical practice, but this term is actually a misnomer because physicians have an obligation to make reasonable decisions and judgments under time pressure constraints and limited facts. And in retrospect, they may not be considered to be the best decisions, but they're not negligence. Errors can also occur due to delays in diagnosis because many conditions must progress to a clinical degree where the symptoms and signs can lead to a diagnosis or at least indicate the need for further testing. So I want to present to you two cases. The first case is a 56-year-old woman who presents with a nodule on a screening mammogram, and investigations proved to be cancer. The surgeon reviews the patient's previous mammogram and notes that there are microcalcifications and architectural distortions suggestive of a malignancy on a previous mammogram. This could have been recognized and investigated. Is this error or is this negligence? It's not clear. In a second case, a 56-year-old woman develops atelectasis following elective ventral hernia repair, and a chest x-ray is done in the hospital. She recovers and is discharged home from the hospital without incidents. However, months later, she presents for a shortness of breath and cough, and report of another chest x-ray from her current investigations showed potential for a nodule, and review of the previous chest x-ray shows that a finding of the suspicious lung cancer has not been followed up by her surgeon. Is this negligence? How do we disclose errors when we don't know? And it's unclear, and in most cases it isn't, when something is an error or a negligence. Disclosure is a process by which some form of harm from healthcare delivery or an unanticipated outcome is communicated to patients. This is very difficult and sometimes not done properly. In fact, 22% of physicians disagreed with the need to disclose minor errors at all to patients. This was in a survey done of 26,000 patients in Canada and the US. So when do we disclose an adverse event? We disclose, in many cases that I will outline here, sentinel events are reportable. It is an unexpected occurrence involving death, permanent harm, or severe temporary harm to a patient. There are lists specific to hospitals and institutions of sentinel events that are reportable and require a risk manager to help prepare for disclosure to patient. Any harmful incident that happens to a patient must be disclosed, and hospital risk manager must be involved in the disclosure. If there's no harm to the patient, however, an error has occurred, this also generally is disclosed to a patient, however, it may not involve the risk management. Any natural progression of the underlying disease or inherent risks of investigations or treatment are, of course, discussed with the patient directly by physicians without the risk management involvement. Important to note that near misses generally do not need to be disclosed to patients unless ongoing safety risks for the patient occurs or a patient is already aware of this. What are some of the pitfalls of the disclosure? Number one, do not rush to disclose. Get help. There are officers in your institution that deal with risk management and are there to help you go through the process in a professional manner. Do not alter the medical record. A deliberate attempt to change the medical record almost always guarantees settlement of even medically defensible cases. Secondly, do not use the term error. Although there may be some clear cases of error, this term is fraught with nuances and interpretation and generally should be avoided in disclosure discussions. Avoid blame and shame yourself and others. This may lead to medical legal consequences, and any kind of blaming and shaming can prevent any institutional changes from taking place and improvements to the quality of care patients to be provided. Another pitfall is the hindsight bias, where knowing in retrospect that an undesirable or unexpected clinical outcome has occurred, physicians can have a belief that it was their carelessness or fault, and this may be communicated to patients when in fact this was not the case of fault or negligence. Lastly, this may be obvious, however, important to state explicitly is that there's absolutely no role for in the disclosure process for physicians to offer any monetary or other compensation to those affected. There are special risk management procedures in some institutions for disclosure, apology, and rapid offers of compensation. However, this is never done by the physicians. So next, I want to share with you the disclosure roadmap, which starts with addressing the clinical needs of the patient and making sure that you are the appropriate individual or team to provide further care. This may be a time to pause and consult another surgeon or physician, or transferring the care entirely, which could be in your or the patient's best interest. The reasons for a transfer of care must be very clearly delineated to the patient because they may feel abandoned. It's always important to document all the facts in the medical record, as this may be subject to discovery later down the road. Next step is to plan the initial disclosure, and most importantly, contacting your risk manager in your institution. Only then you can go over the facts of the case and plan what information should be given to the patient, in what format, and where, who, and when the meeting takes place. You may also consider having other providers present or other family members of the patient with the permission of the patient. Remind your disclosure team that this conversation is solely for the benefit of the patient and the family. Discuss the need for the team to present themselves in a unified manner. And there's no script to follow. Be genuine, sincere, compassionate, and set the agenda for the meeting so the patient and the family knows what to expect. Provide known facts and be sensitive to how much your patient can be ready to hear. Again, do not speculate, blame others, and assess whether existing clinical relationships can be maintained in this situation. Be prepared for adversity, as these disclosure discussions may not be greeted with a thanks or forgiveness. When disclosing bad news or adverse event to a patient, it is important to know what patients want to hear. And they want to hear an acknowledgement that something has gone wrong, even if it's minor, because if it's not minor to them. And an understanding of the recommended next steps in clinical care are very important. Make sure that the patients also understand the facts of the case and express a genuine concern and regret for what has happened. Reassure the patient that appropriate steps are taken to prevent a similar occurrence from happening again to themselves or others, and decide who will take primary responsibility for following up with the patient, as this can be ambiguous in some instances. Conduct a post-conversation huddle, a debriefing with your team. Make sure that emotional, psychological needs of the clinicians involved are addressed, and arrange for perhaps temporary relief from clinical duties or additional supports if necessary. This should never be included in the patient's medical record. However, document the disclosure events and make sure you write down that all of the questions of the family or patients were answered. And agreed on next steps are clearly delineated in the record as well. Again, do not offer any monetary or other compensation. Is it safe to offer an apology? Studies suggest that patients affected by adverse outcomes strongly prefer explicit apologies, and such apologies, while not a panacea, may prevent lawsuits and promote faster and smaller settlements in the future. Therefore, do express an appropriate form of apology or regret. Do not, however, use words that express or imply legal responsibilities, such as negligence or fault, or reference any failing to meet a standard of care. Use your words carefully and wisely. Stating that you're sorry for the circumstances or the condition of the patient is an expression of genuine concern and regret, and will be appreciated. You will never be faulted for being empathetic. So we always ask about apology laws. 36 states have apology laws, and those protect certain statements and expressions that physicians can make during disclosure. And those then are inadmissible in the court of law if a malpractice suit is undertaken. Majority of states have enacted laws to encourage expression of empathy or sympathy, and a few states actually go even further to protect physicians in admissions of fault. However, you must pay attention to the fine print and to the details of what your state actually considers inadmissible, as these laws differ from state to state and in different countries, of course. And the bottom line actually is that you don't need apology laws to provide good disclosure. Empathizing, like I said before, will never get you in trouble. So in terms of the internal reviews for quality improvement in the hospitals, the most common one is the root cause analysis performed, which is mandated by the Joint Commission to analyze sentinel events such as wrong site surgery. Majority of states have mandated reporting of serious adverse events using the National Quality Forum's list of never events, and many states also require the root cause analysis to be performed and reported after any serious event. So is an RCA privileged? Yes, the answer is yes. However, you must always read the fine print. Confirm with your institution and legal counsel in your state or country that the RCA is actually privileged. For example, in New York, it is important to know that the least protected statements in an RCA are those made by the physician themselves in relation to their care of the patient, especially if they are later named as a defendant in a malpractice action. So out of an abundance of caution, the risk guidance to physician is that to be careful is important. Do not speculate, offer opinions, or allocate fault about your own or anyone else's care. Allow the peer and quality reviewers to offer the final opinions of fault, standards of care, and other patient items. Most of what you say during a QI initiative such as the RCA should be afforded privilege based on either the state or federal statute as listed here. This is provided, again, the fine print, this is provided that the institutions meet all the stipulations conforming this privilege. You must check with your institution. For example, in order to have protection under the Patient Safety Act, the hospitals are mandated to participate in a patient safety organization, PSO, that receives their reported data and uses it to develop patient safety improvements. My hospital, for example, is a member of a PSO organization called ECRI. So the federal privilege is granted in our QI meetings through ECRI. Lastly, but most importantly actually, is to manage physician stress. It is normal to be emotionally affected and feel guilty when a patient suffers from a serious complication. It's important to take care of yourself, avoid hindsight bias, and analyze the event objectively. Set limits for the time you will think about this event, and take time off to treat yourself as you would treat your best friend. If you made an error, allow yourself the same compassion and grace that you would accord to others. There is no need for judgment. Focus on what you can learn from this event. Respond professionally and seek personal support. You do not have to go it alone. Stay connected with your patients, colleagues, family, and friends, and maintain normal relationships. Reach out to your employee resources available at your institution to get professional help. This concludes my talk. I would like to highlight that a majority of my sources for my topic has been my own institutional policies and procedures for Sentinel event disclosure and reporting, and as well a very comprehensive summary provided by CRICO Insurance Program and the Canadian Medical Protective Association, which has a very thorough information on their website. These are some of my references. Thank you for your attention and enjoy the rest of the meeting.